Right ventricular systolic function can be evaluated in terms of right ventricular fractional area change and right ventricular ejection fraction. There are other Doppler and strain imaging methods as well. Right ventricular dP by dt or rate of rise of right ventricular pressure can be estimated from the tricuspid regurgitation Doppler jet. While the left ventricular dP by dt is over 1200 millimeters of mercury per second, that of the right ventricle is over 400 millimeters of mercury per second. Tricuspid annular plane systolic excursion (TAPC) is another measure of right ventricular systolic function. It can be measured in the four-chamber view using M-mode echocardiography. TAPC is a measure of right ventricular longitudinal function. Normal value is usually above 15 millimeters. It is a highly load-dependent measure and optimal alignment of the ultrasound beam can be challenging. Right ventricular fractional area change can be measured from the four-chamber view by tracing out the diastolic and systolic frames. Fractional area change FAC is equal to N diastolic area minus N systolic area whole divided by N diastolic area. Normal values range from 32 to 60%. Fractional area change is highly load dependent. Complex geometry of the right ventricle and the coarse trabeculations make tracing out the right ventricular area challenging. Still, there has been good correlation with right ventricular ejection fraction measured using magnetic resonance imaging. Right ventricular ejection fraction can be calculated using the Simpson's rule. Right ventricular outline is traced out in systole and diastole as for left ventricular function evaluation by echocardiography from the four-chamber view. It has been shown to have prognostic value in heart failure, valvular heart disease and congenital heart disease. But it is highly load dependent and can be inaccurate in volume and pressure overload states. Precise measurement of right ventricular ejection fraction is often difficult due to the complex geometry of the right ventricle. There are several limitations due to the geometry of the right ventricle. Assessment of right ventricular diastolic function is often done by echocardiography, though not as commonly as for the left ventricle. An RV-focused apical four-chamber view is used for the assessment of right ventricle. In RV-focused view, transducer is adjusted from the standard apical four-chamber view to have right ventricle in the center of the image than the usual image centered on the left ventricle. The left ventricular outflow tract should not come into the view and left ventricular apex should remain at the top of the image sector. In this adjusted view, the entire right ventricular free wall should be visible. Right ventricular diastolic dysfunction may be associated with various congenital heart diseases, cardiomyopathies, left-sided valvular heart disease, and systemic conditions like diabetes mellitus, rheumatoid arthritis, and conditions causing vasculitis. Assessment of right atrium, right ventricle, and inferior vena cava by two-dimensional echocardiography gives indirect evidence on right ventricular diastolic function. This is so because significant elevation of right-sided filling pressures would alter the right heart dimensions, size of the inferior vena cava, and its inspiratory collapse. As in the case of mitral valve, assessment of tricuspid inflow velocities is a simple way to assess right ventricular diastolic function. E by A ratio and deceleration time of the E wave can be recorded using pulsed Doppler cursor at the tip of tricuspid valve leaflets. It may be noted that tricuspid inflow is highly sensitive to preload, afterload, and phase of respiration. Hence, averaging 5 consecutive beats or measurement in held expiration have been recommended. As on the left side, absence of a wave in atrial fibrillation would mean that EA ratio cannot be measured. Tissue Doppler at lateral tricuspid annulus can be used to measure the E prime, A prime, and E prime by A prime ratio. Right ventricular isovolumic relaxation time can be calculated using tissue Doppler. E by E prime ratio can also be calculated as on the left side. Similarly, T index or myocardial performance index can also be calculated. Right ventricular tissue Doppler indices are less load dependent than pulse Doppler right ventricular inflow measurements. Myocardial performance index is the ratio of the time spent in isovolumetric activity divided by the time spent in ventricular ejection. MPI is equal to ICT plus IRT whole divided by ET. ICT, isovolumic contraction time, IRT, isovolumic relaxation time, ET, ejection time. T index can also be measured indirectly from the tissue Doppler. It is designated as TMPI. Corresponding measurements on tissue Doppler are TIVCT, tissue isovolumic contraction time, TIVRT, tissue isovolumic relaxation time, and TET, tissue ejection time. Measurements are taken using pulsed tissue Doppler from the lateral tricuspid annulus. Pulsed wave Doppler interrogation of hepatic vein flow is another method of assessing right ventricular diastolic function. Interrogation is done from the subcostal view. As in the case of other right-sided parameters, velocities are more in inspiration. Hence, averaging of 5 consecutive beats is recommended. Hepatic vein Doppler shows systolic S wave, systolic reversal SR wave, diastolic D wave, and atrial reversal AR wave. Normally, S wave is dominant as IVC fills rapidly and empties the right atrium in ventricular systole. Small SR wave may be seen in late systole. D velocity occurs during right atrial emptying in diastole. A small AR wave is seen in late diastole when atrial contraction completes right ventricular filling along with small backflow into the hepatic veins. In right ventricular diastolic dysfunction, there is diastolic flow predominance with S bar D reversal. Other reversal velocities are also increased in right ventricular diastolic dysfunction, more so in inspiration.